Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we're now going to talk about acute tubular necrosis. So right off the bat, one thing I want to highlight here, that acute tubular necrosis is a subtype of intrarenal AKI. And remember, in our video about intrarenal AKI, we said that there are a variety of different things that can cause it, but acute tubular necrosis is the most common one, accounting for approximately 85% of intrinsic acute kidney injuries. So first we're going to talk about the pathophysiology here. The first one we're going to talk about is ischemic. So in ischemia, we get a decrease in renal blood flow, right? Ischemia means that we're not getting enough blood flow to our organs, and this decrease in renal blood flow is going to lead to necrosis of the cells in the tubules, in the kidney, and affect our filtration system. So if we have necrosis of these cells, they're going to slough off into the tubular lumen. And if they slough off into the tubular lumen, we're going to have an obstruction that ultimately decreases our GFR, increases our BUN and creatinine. So what do I mean by this? Well, what I mean is that if we look at our PCT, for example, it's lined with a variety of cells. If these cells are ischemic, if they don't get enough blood flow, they necrose and they die off. Well, they're going to die off into the lumen. So we get necrosis of these cells. I'm wiping them out with a black X. And what happens is that they actually fall off into the lumen and they create an obstruction. They create what's called a cast in the lumen. And this urinary cast is the obstruction that causes there to be an increase in retrograde pressure into the glomerulus. And so we have an increase in retrograde pressure into the glomerulus. We get this decreased GFR because now instead of going from a high pressure system into a low pressure system, we're going from a high pressure system in the glomerulus in Bowman's capsule towards another high pressure system. Again, it's a high pressure system because we have an obstruction, because we have a renal cast. Typically, it's a low pressure system and things move along accordingly. But once we create this obstruction, we create this tubular cast. Now we have a high pressure going to a high pressure, leading to the decreased GFR and ultimately the elevated BUN and creatinine in the body. The reason BUN and creatinine elevate is because we're not able to filter these substances as much as we normally would. Now, we can also get damage through nephrotoxic injuries. So toxic injuries to the cells can also cause the same thing. Cells to slough off into the tubular lumen, creating an obstruction, decreasing GFR, and increasing BUN and creatinine. The pathophysiology is very similar, but the causes are different. Some of the primary causes that they want you to know include things like contrast agents, aminoglycosides, cisplatin, amphotericin, lead, myoglobin, and hemoglobin. There are a variety of different things that can cause toxic injury to the kidneys, but these are the ones that I see most commonly tested. Now, one thing I want to mention here that might seem like a little bit of a detail, but I see commonly tested is where in the tubules are we most likely to see these effects occur. So ischemic injury is more common to be associated with the straight segment of the proximal tubule and the thick ascending limb, which goes toward the distal convoluted tubule as well. Contrast this with nephrotoxins, which is more likely to be associated with the convoluted segment of the proximal tubule. So the PCT is kind of broken up into two portions, the straight portion and then the convoluted portion. Ultimately, this leads into our loop of Henle, goes around to the DCT and through the collecting duct. Now, one final thing I want to mention here before we move on is regarding the terminology that we use when we talk about kidney injuries. So an ischemic injury, right, can be due to decreased blood flow. What we've talked about in previous videos, that decreased blood flow to the kidney is more indicative with a pre-renal acute kidney injury. And so you can see how AKIs are not necessarily mutually exclusive, right? There is some overlap between pre-renals and intrarenal and post-renal. It's also important to know that the nephrotoxic agents that can cause acute tubular necrosis are more indicative of an intrarenal acute kidney injury. So you can have this overlap where your patient starts with hypotension, they have a pre-renal AKI. This can then develop into an intrarenal AKI or acute tubular necrosis. And when we talk about acute tubular necrosis, we talk about a few different phases that patients go through when they experience this condition. So we'll break it up into three phases here. And the first phase is going to be an inciting event. So this is our initial kidney injury. We said the two primary ways this is going to happen is either through an ischemic injury or a nephrotoxic injury. So either of these can occur and create an inciting event for the kidney to be damaged. After this inciting event occurs, we undergo the maintenance phase, which usually lasts for 1 to 3 weeks. Important point here, this is an oliguric phase. Remember our terminology. Previously, we said that oliguria is relating to a decrease in urinary output versus anuria is relating to absent urinary output. When we have an oliguric phase, we have an increased risk for hyperkalemia, uremia, and metabolic acidosis. And can you think about why this might be? That's right, because if we're experiencing oliguria or we're not excreting as much urine as we typically would, we're going to get a buildup of these metabolites in the body. We're going to have too much potassium, too much urea around. Typically, we would filter these substances and excrete them from the body. But if we have decreased urine production, we're decreasing the ability to excrete these substances from the body. And then third, we're looking at the recovery phase. So this is a really important phase as well, and this is described as a polyuric phase. So essentially what happens is we talked about how there's necrosis and the cells can die off. However, the kidneys are really resilient and they can actually undergo a process called reepithelialization. And this process can actually lead to full recovery of the kidney itself. This is very important though, because we have a damaged kidney from an inciting event. It undergoes a maintenance phase. But during this last phase, the recovery phase, in the tubular epithelialization, we get an increased risk of hypokalemia and loss of electrolytes, along with a decreased BUN and creatinine. I want to really highlight this point here that in the maintenance phase, we can get hyperkalemia, but in the recovery phase, we're more likely to get hypokalemia. And the reason is during the recovery phase, when we get this cellular healing occurring and the kidney regains its function, we have this polyuric phase where we're excreting an excessive amount of urine. And an excessive amount of urine production leaving the body is going to take along a lot of electrolytes, including potassium. And this can cause a hypokalemic state. So it's really important that we monitor these patients to make sure they're not going too low or too high with their potassium as they're recovering from an acute tubular necrosis. The etiology here is going to be pretty straightforward based on what we've already talked about. There are two primary causes, including ischemic and toxic intrarenal AKI. And it's also important to know that acute tubular necrosis is the most common AKI or acute kidney injury in hospitalized patients. The reason for this being because they typically are there for a variety of ailments that can actually cause hypotension, blood loss. This can lead to a prerenal AKI, ultimately leading to ischemia to the kidney. Additionally, a lot of hospitalized patients already have pre-existing acute kidney injuries. They might be undergoing some imaging studies and might need some contrast, or they're dealing with a lot of different medications that can actually be toxic to the kidney itself. When we talk about the presentation here, we're really going to keep in mind that this is going to present very similarly to an acute kidney injury. So we're going to see things like oliguria, anuria, volume depletion, potentially edema, and there are a variety of different ways a patient can present when they have an acute kidney injury. The presentation often depends on what is the actual thing causing their kidney injury, and so there's not really a one-size-fits-all presentation. However, it's also important to know, as with other types of AKI, this can be an asymptomatic presentation. Patients may not know that they're actually undergoing this until later on in their disease. As it progresses, the symptoms tend to be more and more obvious, and that's when patients might get checked out or go to the hospital. This is why it's important that we're always monitoring patients' labs and checking, are they changing on a day-to-day basis? Are they trending in the right direction, or are they trending in a direction that makes us more concerned? And finally, a pretty notable thing is that patients with acute tubular necrosis are going to have changes in their urine volume production, right? An oliguric phase versus a polyuric phase would be fairly obvious to a patient, something that they might tell you about, or something that you might notice if you're continuously monitoring them on a day-to-day basis. When we talk about the diagnostics here, I really want you to remember what's fairly pathognomonic for acute tubular necrosis as far as board questions go, and this is the muddy brown granular cast, super high yield. If they mention any kind of muddy brown cast in the urine, that's the first thing I want you to think of. Here's an image of it over here, and the reason is because they're basically telling you that the patient has had a urinary obstruction that is now presenting in the urine sediment. So if this obstruction was right here in the PCT, it can actually make its way all the way down through the nephron and out into the urine. And then we can see that on the urine sediment as a muddy brown cast. And the other key one I want you to know is that these patients are likely to have an electrolyte derangement. We talked about why that might be, right? There are different phases of acute tubular necrosis, and depending on that phase, we're going to say, is this patient more likely to be retaining electrolytes, retaining potassium specifically, or are they more likely to be low on electrolytes, potentially have a hypokalemic state? So always be really mindful of the labs when you're dealing with a question that asks you about patient's kidney function. Now, when we talk about management options here, we're going to want to stop anything that could be contributing to the patient's condition. So stopping nephrotoxins is going to be one of the first things that we want to do. Additionally, we're going to provide supportive care. If the patient has electrolyte derangements, well, we're going to help monitor those and potentially give them a variety of different treatments to keep those levels in balance. We're also going to monitor the patient for their different stages of acute tubular necrosis. If they're in a polyuric phase where they're losing a lot of fluids, we might need to replenish those fluids. We might need to replenish some of those electrolytes that they're losing during that phase of acute tubular necrosis. It's also worth noting that in acute tubular necrosis, kidney function typically recovers. We talked about this, how the cells can regenerate and actually return to fairly normal kidney function, if not completely normal kidney function. And so because we know that this typically happens, we're really trying to help the patient manage the symptoms while the body helps to heal itself. And finally, a key clinical point I want to make is that to prevent contrast-induced acute tubular necrosis, we can prehydrate the patient with an excessive amounts of fluid. We talked about how one of the nephrotoxins is contrast. Well, we know in hospitalized patients, a lot of times they are going to get imaging, and a lot of times that imaging is going to use contrast. So if a patient has pre-existing kidney injury, one way we can do to help manage that is to give them enough fluids to help balance out that contrast load. so the contrast is not as toxic to the kidney. We're essentially trying to dilute that contrast that we're giving the patient in hopes that it will cause less damage to their kidneys overall. So a classic clinical vignette that they might give you talking about acute tubular necrosis would be something along the lines of telling you that a 70-year-old patient presents to the hospital with some abdominal pain. They would tell you that their medical history includes things like diabetes, kidney disease, and all of these various medications that they're taking as well. Now, the patient gets admitted to the hospital and undergoes a CT scan to assess their abdominal pain and figure out what might be the potential cause. The following day, they get labs on the patient and their serum creatinine has elevated from 0.8 to, let's say, 1.5. Now, up to this point, you should be thinking out what kind of things might be causing this significantly elevated creatinine for this patient, but maybe they'll even give you more information. Maybe they'll tell you that a urinalysis was done, and lo and behold, they see muddy brown cast on the urine sediment. Well, now you know that that's fairly pathognomonic at this stage as far as answering questions for acute tubular necrosis, and that's most likely to be the patient's condition. So that's one of the classic primary ways that they would ask this in a question stem, but keep in mind, they could substitute contrast for any of these other nephrotoxins as well. They could also substitute a patient getting contrast with a patient who is likely to experience ischemia, maybe someone who's been in a motor vehicle accident. They've had a lot of blood loss. 2 days into their hospitalization, their creatinine spikes up from 1.0 to 2.2. This might be indicative of acute tubular necrosis as well. So just quickly summarize this video and give you guys a couple take-home points. When we think about acute tubular necrosis, two primary causes: ischemic, nephrotoxic. A handful of things can cause the ischemia. Many things can cause the nephrotoxicity. The classic presentation for these patients is really going to be signs that are similar to acute kidney injury. Do they have changes in their urine output? Do they have hypertension? Do they have edema or volume depletion? There's a variety of different ways this can present. So we have to use all of our clinical clues. We can't just purely base our assessment off of the patient's presentation. It's also important to note that this can be asymptomatic, particularly early on. A patient might not know they are developing this condition, but typically later on, it's more likely that signs and symptoms will begin to show. When we look at the diagnostics, really want you to focus on this urine sediment, which is most likely to tell you about muddy brown cast. Now, it's worth noting you can also see epithelial cast as well, or even free tubular cells that have not formed a cast shape, but typically a question stem is going to ask you about the muddy brown cast, so that's the one I really want you to memorize, but just know in the back of your head, there are some other casts that can present as well. Finally, when we talk about management here, we're talking about stopping nephrotoxic medications and providing supportive care to the patient. Why are we providing supportive care? Because typically this can recover on its own. Kidneys are able to regenerate their cells and restore their function. And so we're really just trying to buy time and manage the patient's symptoms to allow the body to heal itself. Finally, a key clinical correlation I want you to be familiar with, if they talk about contrast-induced nephropathy or ways to decrease the risk of this occurring, it is going to be to hydrate the patient before contrast. This essentially tries to help dilute the contrast so it doesn't cause as much destruction to the kidney itself.